It's 5 p.m. Welcome to the first meeting of 2019 of the Indian River County Hospital District. Seems like there's already been a lot.
Yeah. A lot going on.
It does. So welcome to everybody that's in the audience. Welcome to anybody that's watching on TV, and Happy New Year to everybody that's out there. We do have Barbara is on the phone today, so if people can make sure and speak up so that she can hear, and we'll take time to make sure that she understands what's going on. Our first course of action, as every January is to take care of organizational matters and election of officers.
Say a prayer?
Oh, I'm sorry, it doesn't have a prayer on it. Kate, you messed me up, I'm sorry.
I know that
Okay, so we will start with a prayer, and Tracy, would you lead us? Thank you. You know?
All right. Well, Happy New Year to everybody. We can still say that, right? It's still January.
Yes.
So I wanted to read something from Isaiah 43, verse 19, and it says, "See, I am doing a new thing. Now it springs up. Do you not perceive it? I am making a way in the wilderness and streams in the wasteland." And I just thought that was appropriate for all the new things that have happened since January 1st and everything that led up to that I thought it would be appropriate to kind of spark the new year with a blessing like that. So if you'll join me in prayer. Dear Heavenly Father, thank you so much for today and the opportunity to come before you and gather here together to do your will in regards to our community, the health of our community and all its residents and those that come to visit us. I pray your blessing on tonight's meeting. I pray that this new year would be bright and full of exciting moments that show your blessing on this community. In Jesus' name, amen.
Amen. Thank you, Tracy. Michael, you lead us in the...
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. Thank you, Mrs. McChrystal, for reminding us. Okay. So election of officers, and Jennifer, I'm going to turn it over to you.
Okay. The bylaws of the Indian River County Hospital District require that the district reorganize at the first meeting of each year, which is tonight, and elect 5 officers. Any members may make a nomination for any of the 5 offices. The 5 offices to be voted on tonight include chairman or chairperson, vice chair, secretary, assistant secretary, and treasurer. Each office will be elected by calling for a nomination, a second, and a motion to close the nomination. So we're going to start with a nomination for our chairperson position. Do I have a nomination?
I do, may I?
You may.
It was a little more than a year ago when Mary Beth Cunningham, through her wisdom, vision, and dedication, initiated discussions with the district trustees and members of the board of directors of the hospital to explore the possibility of engaging a health system partner for Indian River Medical Center. The ultimate conclusion, and I'm proud to say unanimous decision, was the affiliation with Cleveland Clinic, Florida. I wish to applaud Mary Beth for her leadership role in this most historic event for our hospital and for our community. And therefore, I move to nominate Mary Beth Cunningham, Chair of the Indian River County District Board of Trustees, to continue in the role she has so wisely represented.
Wow.
Okay.
Second.
Okay, so we have a motion and a second. Any discussion?
Just to validate what Anne Marie said, I think the leadership that Mary Beth has brought to this entire relationship between the hospital and the district has been maybe legendary. Anyway, thank you.
I think the fact that we were able to get a unanimous decision shows the ability and leadership of Mary Beth to do what would seem impossible at the beginning to people. But she did it, and we had a unanimous decision based on her work.
Well, guys, I am humbled. I am humbled by what you said and very appreciative. It has been a wonderful experience, I think, for all of us, a once-in-a-lifetime experience, I hope. I hope. But it's been because of the great board that we have, too, so it's been good.
Okay, so
vote?
we'll call the question, and all those in favor of the nomination for Ms. Cunningham for the chair?
Aye.
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 Any opposed?
You
Hearing,
need to ask Barbara.
Barbara, can you hear?
Aye.
Okay, thank you. So the motion carries unanimously. Mary Beth will be our chairwoman. And we'll move to vice chair now. Do I have a nomination for the vice chair of our board?
I'd like to nominate Michael Weiss, please.
Okay, is there a
I'll
second?
second.
Any discussion? Okay, we can close that, and you guys can go ahead and vote for that.
Aye.
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 Barbara?
Aye. Aye.
Thank
Okay.
you very much for your confidence. I appreciate it.
All righty. Dr. Weiss will be our vice chair again this coming year. And we'll move now to nominations for our secretary.
I would like to nominate Mrs. McChrystal. She does a great job at keeping us on track and with the right words.
Second.
Okay, any discussion on that? Okay, hearing none, you guys can go ahead and vote on that.
Aye.
Barbara?
Aye.
All right.
Aye.
Okay, it is unanimous. Mrs. McChrystal will be our secretary. Now we'd like to call for nomination for assistant secretary.
Would you be interested, Stacy?
Sure.
I would nominate Stacy Zudans. Tracy Zuzans. Tracy.
A second.
I'm
Okay.
sorry about that.
Absolutely.
Okay, any discussion?
No.
Hearing none, you guys can go ahead and vote for the assistant.
Aye.
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 Okay, it is unanimous. Mrs. Zudans will be our assistant secretary. And last but not least, a nomination for our treasurer position, please.
I would like to nominate Alan, who's been doing a tremendous job, probably best treasurer we ever had. And I appreciate all that Alan does for us and for the community. Therefore, I would like to nominate him.
Second.
Okay, any discussion on that? Hearing none, you guys can proceed to vote on the treasurer.
Aye.
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 Okay, it is unanimous. Mr. Jones will be our treasurer, and that will close the election for this fiscal year.
All right.
Thank you.
Moving on, we need to talk if we want any change in the frequency of meetings, the time and day of meetings, and the meeting location. So let's start with this regular meeting first. Are we good to keep 5 o'clock on the third Thursday of the month?
I'm fine with that.
Fine.
Michael?
No problem with
Alan?
that. That's good.
Fine.
Barbara?
Aye.
Okay. And then generally, we've been having the chairman's meeting.
Aye.
Okay, Barbara's good with it. At 10 o'clock on Wednesdays before the Thursday meeting, so everybody's good with that, to keep that going? All right.
Good.
And the frequency of meetings, I don't know that we're going to talk about because we are going to have them when we need to have them, and we have topics in front of us, and we will continue to do that as needed, if that's okay with everybody.
Absolutely.
Should be as needed. Great.
Okay.
Very good.
Moving along on the consent agenda, if I could have a motion for the approval of the chairman's meeting minutes dated December 19th, the regular monthly meeting minutes dated December 20th, and a December disbursement of Mr. Jones.
$1,206,053.66.
Okay, That's different than the paper says.
Yes, but that's the accurate number.
Okay. All right. Can I hear a motion?
So move.
Second?
Yeah, second.
Okay. All in favor?
Aye.
The only thing that I really have to report right now is, of course, we have a lot of things going on. One might have thought that things would calm down for the district, but they have not. And so we continue to work on the Gifford Health Center and making the right decision there and moving forward with that. And a number of other things, our strategic plan and understanding what it is we're going to focus on here in the next few years. So a lot of work and learning to be done in relative to that. One item I do want to bring up, it has been brought to my attention that our meeting in March, which would be March 21st, is spring break, okay? And while most of us don't get concerned about spring break much anymore, because we don't even know it is spring break, there are several people, the staff folks particularly, who would like to take time off during that week to share it with their kids and that. So the request has been made if we could move that meeting. Don't have dates yet on we don't have dates yet on what's available, but Kate will send something out. So if you guys are okay with that. Okay? Okay.
Yeah,
Okay.
That's fine.
All right, then Kate will send out notice on those two. Okay, District Council, Jennifer.
Okay. So several things on here you've heard from me before. We've continued to work with the team at Gray Robinson to complete the closing, which, as you all know, occurred on January 1st. And right now, we're just in the process now of finalizing the closing binders and post-close items that they've provided us with, and going through the due diligence of those dates and putting up ticklers for that so that we keep on top of that this coming year. Have also assisted, again, with finalizing those documents and attended the final conference call where we did close and agreed to release the documents. I also attended the January 8th Gifford Health Council meeting, which was last week, as we are continuing to finalize the matters concerning the Gifford Health Center, and have attended and participated at the district special strategic planning meeting that was also this month, and look forward to working on these continued projects this coming year with you guys. Does anyone have any questions?
Just a comment on the post-closing. Gray Robinson, I think, did a very nice job of going through all of the agreements we have and all of the things that need to be done or need to be aware of, things that, within the agreements, like we have the right to go in and do audits with the hospital and some of those kind of things. So they put that all in a very nice form for us to be able to, so we don't lose track of what's in the agreements.
Yes, they were an excellent team
so.
to work with, and excellent all the way through with everything they gave us.
So we were very pleased at that. So we're going to spend some time and make sure that we've got the right ticklers in place for that. Okay, financial statement review. Mr. Jones.
Thank you. And Michael, thank you for your comments. I appreciate that.
Well, they're well-deserved.
They are well-deserved.
Absolutely.
I'll make this a brief report tonight. So first of all, the district remains in sound financial condition. I know you'd be comforted to hear that. And I'm pretty impressed with the taxpayers of Indian River County who continue to promptly pay their taxes. Those bills, tax bills, most people don't get them until November, and we've already received 83% of the funds that we're going to get for the year.
Wow.
That was through December 31st.
Got a bunch more today.
So as of year end, our bank account has swollen to about $12.8 million, less than $1,206,000 we just spent. And speaking of that, a couple quick points about the money expenditures we just approved this evening. One was, I note they have a check to IRMC for $667,000 and change for indigent care. That's the amount. Then the amount of indigent care, incidentally, at the hospital continues to surge. Year to date, October to now, total indigent care going to the hospital is up 17% from a year ago. and a year ago was up 17% from the year before. But this month's check marks the end of the district's exposure to this surge in volumes. Next month, our payment will be reduced to $500,000, and it'll remain at that number in accordance with our agreement for 30 months. So that's a reduction of some $167,000 immediately. After the 30 months, the district will be out of the cost supporting of indigent care treatment at the hospital and will realize substantial savings as a result. Secondly, there is a check in here to Gray Robinson, who are our attorneys, as we've noted, represent the district in negotiations with the Cleveland Clinic transaction. And though there are some remaining outstanding charges to be paid on this, overall this expense has likely peaked and will also be declining from here on out. So we have a number of things to occupy our efforts to try to improve healthcare in the county. But two things, the hospital and the outside counsel, we should see declining expenses in the future. That's it. Thank you.
That's good. Okay, the executive director report, Anne Marie.
Okay, I think, I know that you do not have a written report in your book, if you noticed that. I'm sorry about that once again, but I will make a couple of comments. A lot of the work that has been surrounding the office in the district has been around our consideration, your consideration of looking at the 250% of the poverty level as opposed to 150 or some number in between there. And the work that we talked about yesterday at the chairman's meeting. So those activities will continue. I'll get out to you with the minutes, or maybe before, the parameters around there, as you asked, that we talked about yesterday. The work with the strategic plan has been another consumption of time. Like Mary Beth said, we thought things would slow down, but those two activities are, and the Gifford Health Center, obviously, which I'll talk about for a second next, is a lot of the work that we are doing now. And so I know that each of you are involved with those things, but there's a lot behind the scenes, I guess, that happens during a course of a day. So the Gifford Health Center, as we mentioned, we had a conversation about that yesterday, and so I guess for anybody else that wasn't there, that we are going to continue to proceed with an RFP process now that we have found all of the information and investigated and looked at and listened to the people. So Will, Alan, and Jennifer and I will be working on putting all of those things together. I think that's it.
Just as a note,
questions?
I was in a meeting last night with Michael Kent from the United Way, and the new ALICE information is out. And one of the, I guess, startling things is that Indian River County, the percentage of those what I would call working poor and poor has gone up.
Okay.
And so that just says more impetus into what our discussions are.
Madam Chairman, could you just explain for the listening audience, Alice?
What ALICE is?
Yes.
ALICE, and I believe that's a United Way term
Right.
that they use, but it's asset limited, income constrained employed. So it's those folks that have jobs that are working every single day, but are doing just what they have to do to make ends meet. And any catastrophe or anything like that, causes huge problems for them. So it's other names are the working poor, I guess, is another way of putting it. But so we should get our hands
with
on
Michael and get the report, and if
yeah.
you're interested,
Yeah, I
I'll
think
send it
that
out
we've had it
to
in
all
the
of you.
past,
Yes.
and I think it's a good report too, so we can update ourselves as we move forward.
Actually, he
where
said
we're
we weren't
going.
even supposed to know about it yet, but
Well, now they do.
now a lot of people do. So, so there we go.
Maybe
but-
he'll thank you for that.
Maybe. So, yeah. So let's get our hands on that, and that'll help our discussions, I think, going forward as well. Okay, our funded agencies report. The first up is the health department. Miranda? This is
There you go.
There we go.
All right, thanks for letting me present tonight on the quarterly report. This is for the period July through September. So in terms of our main site, our total district visits were 485. For total visits for the site were 2,036, so the proportion is 24% for the district. Dental, 697 out of the 1,399 visits were for the district. And at Gifford Health Center, 33 of the 1,167, or 28%, was the district. Now, as you see from our next slide, these are patients that are district qualified. These aren't, but the statistics I gave you were patients that were district qualified. We continue to have a large amount of people who are at 100% poverty that we still keep trying to get qualified that struggle. I mean, it's just an ongoing issue. In terms of our payer mix, about 88% of our payer mix is 150% or less of federal poverty. And you can see 65% of our overall payer source are 150%, our self-pay. And so the district's percentage is within that 150%, but it's not the majority. In terms of dental, you can see the splits there, under 100%, about 77%, 19%, 100 to 150, and our self-pay in dental is 49%. We only take, in dental, it's self-pay for emergencies only. Oops, sorry, it skipped. So for Gifford Health Center, it's about 91% that falls into that 100 to 150 category. We have some Medicaid there, private insurance. Managed care is a large proportion, that's managed care Medicaid. And then our self-pay is about 28%. In terms of overall clients, you can see the splits there by site. So the Vero site is in blue. And this is total amount of clients in each of the location for that quarter. In terms of our performance indicators, we had a few that we cited in our application. Percent of 2-year-old clients fully immunized. Our performance in 2017, it's the most recent available, although I can tell you for 2018 it was 100% as well. Percent of CHD, STD cases treated within the 14 days of lab collection, we were at 89%. The target's 90. This past year in 18, that went up. We just reported on that, but it hasn't been finalized. The composite score of core epidemiology measures was 88%. The only reason that is not at the highest level, we had a problem with the phone that it came into, the cell phone technology, because we have to respond within 15 minutes, and we were at the 17-minute mark. Percent of WIC infants who are ever breastfed is 83.7. The target is 79.8, and that is a measure that's gone up. We're very proud of that. And then completed customer satisfaction, 2017 performance is 93.1. That's overall. The data here, the satisfied and very satisfied, is from 2018. And so this is by area. And I knew I flew through that part because I've got to talk about the femur. Do you have questions? Okay. So Cecilia is here from Healthy Start. So when we talk about femur, this is very much a partnership of Healthy Start and of the health department. And technically femurs in the state of Florida are under the Healthy Start Coalition, but we do so much together anyway. It's semantics at this point for us. So we put this together based on some questions coming out of the partners meeting. Just in terms of infant mortality, it's used as an overall indicator for the population. It's really considered a seminal measure to measure health and well-being for public health. When we look at contributing factors of infant health, you've got root factors, which are from the community, intermediate, which are really those maternal factors, and then as well as what you're looking at in terms of immediate factors when you look at all the things occurring with infant health. We also, well, I'll talk about that in a little bit. We completed an infant mortality analysis in 2016. It was part of an initiative for the Department of Health. It was a 10-year look at infant mortality trends. It was an epidemiological analysis. I'm not going to go over that in depth, but I just wanted to touch on a few of the charts so you had it. I know it's very small. I think I heard that up there.
Well, I can see it here. It's on the screen here, so this is.
Well, I'll get you a big copy. But I can certainly send that whole analysis for you. I can tell you in terms of the rates for fetal death, total, our rate is now 6.9 for the 15 to 17 rolling average year. For black infant mortality for that period, it was 10.4. For white, it was 7.6, and Hispanic is 4.9. You know, what is difficult with our mortality, whether you look at the fetal deaths or you're looking at infant mortality, because of our numbers, because they are small, it causes great variation in the statistics. So when we will look at this analysis, that's one of the factors that we've got to take a look at, is how we're going to do it, because we can't just do it for 1 year, because there are only 7 to 10 deaths roughly each year. So in terms of infant mortality, this was 0 to 364 days from 12 to 14. What I can tell you is our recent data, 15 to 17, total infant mortality for that period of time was 7.4. Black infant mortality was 12.0. White infant mortality was 7.2, and Hispanic was 5.0. Right now, the 2018 information is provisional, so we're waiting for that to be finalized, and then certainly we can get that out to you. We did look at 5 select categories of death. They're on the screen: prematurity, congenital abnormality, sudden unexplained infant death, unintentional injury, and intentional injury for homicide. And you can see that on the screen. You know, the greater prevalence of those categories, of course, was prematurity and low birth weight, as well as a sudden unexplained infant death was on there as well, which sudden unexplained infant death is really a catch-all term. And honestly, some of the efforts we've been making through the Child Abuse Death Review Committee for District 19 in terms of getting training out to law enforcement on the on infant and child death examination and investigation, that will help better inform our infant mortality review, because we'll be better off at explaining and really uncovering that causation of death to what right now gets labeled sudden unexplained infant death. So we are looking forward to that. We did that training last year for all Treasure Coast law enforcement, partnered with District 19 Medical Examiner and the State's Attorney's Office. When the State's Attorney invites law enforcement to come, they all come. So that was really nice, because it was an excellent training. Infant mortality, when you look at our county by census tract, the great majority is in Gifford and East Gifford. So at that point in 2014, the rate was 21.28 in West Gifford and 22.39 per 1,000 in East Gifford. That's gotten a little better now. I mean, in 2017, we had 0 African American deaths, which was great for infant mortality. However, because of our past history, we don't expect that trend to be maintained. It would be wonderful if it could. So at this point, what I want to talk about is the femur. and what happens there. So it's a comprehensive assessment. You're looking at social, health, economic, environmental issues, and how those all impact what's happening in terms of fetal and infant mortality. We would gather data. There's a nurse abstract position in this proposal. They gather information from multiple sources. They're looking at everything from autopsy records to the reports from Healthy Start, to the reports from the hospital, to the reports from the pediatrician. I mean, it's a wide-ranging review. And that's an important piece of the gathering process. Also, what's part of that process is an interview with the mother who lost the child. And sometimes that's not always possible, but in the points where it is possible, it really can add to the process and be very informative. Oops, don't go, sorry. The case review team would then, similar to what happens at the Child Abuse Death Review group that I am a part of currently for District 19, all of the different parties come together in terms of, you'd have nurses, community nurses there, you'd have hospital, you'd have Healthy Start, you'd have the health department, you'd have an obstetrician there, you'd have community members specific to part of our coalition that Healthy Start has really developed. All of those people are critical to provide that input into reviewing these de-identified cases for infant death. You're looking at causal and contributing factors. You're looking at if there are gaps in services and gaps in the system that could have contributed. You're analyzing all of those factors as part of this case review. And then ultimately, you're looking at what recommendations could be for improvement. Healthy Start, as you can remember, had instituted the Baby Box program to be able to give a nice, firm sleep surface for infants to be a safe place for them to sleep. That is an example of a wonderful initiative that they started a couple years ago. And then the Community Action Team. That's made up of people from governmental leaders, people like you on the hospital district. I mean, you would be a key partner in this. Looking at different community leaders that would have an input and ability to help make that system change that would be recommended by that case review team. Any additions on there, Cecilia?
I think we.
So the FEMR sequence for case review and community action. So the death would occur, the cases are selected, the data is abstracted. The case review team is reviewing those cases and making recommendations. And then those recommendations are taken to the community action team. And that team would provide that systemic action. And ultimately, it's all about improving health and improving infant outcomes. Case review team, this is just a little bit more about what they're doing, which I've already spoken about. It's also serving, the community action team is bringing this information and making it visible, communicating it widely so people in the community understand how all of these factors work together, and then to improve those services and resources. It's also making sure that those actions that we've taken from the FEMR in the past, that those are maintained, that you're not losing sight of changes that have been made before, that you're still maintaining the improvements that you had. So the and I added another 5,000 there by accident this afternoon. Medical records abstractor position, it would be contract is 25,000 is what we're estimating. Phase 1, the health department would contract with the Health Council of Southeast Florida. They have done this process in Palm Beach County. They have a very nice product from Palm Beach. I can get copies of that for you to review if you'd like. So they would help with following the data gathering, the case review, the community action, help facilitate that piece of the process, and really make sure that people who are participating in the process are happy with how it's going, that they feel that they're listened to, they're making a vital contribution. And then phase 2, of course, is preparation of the report, 10 copies, and then an electronic version on a flash drive. And that's estimate of about 5,000. What I can tell you that I do want to stress is the information from this process, and I hope you can see that from what we've discussed. It's from a systems perspective. However, those systems perspectives are going to be important. It's going to be important for the hospital. There are one hospital. There are infants delivered at other locations beside our hospital, but the great majority is delivered now at Cleveland Clinic, Indian River, right? Okay, good. So it's a fantastic process. We really would love to do it here. We have, I mean, I can't tell you about the collaboration between our two agencies and the potential, I believe, for good, being able to start a FEMR in our county.
Comments?
Yes, I have a number of comments. First, when you talk about the African American population, you're really talking about the Black African population. And I think we should be specific on that and make that clear. You're also talking about the Hispanic population, which has the lowest infant mortality rate of any group, wherever you go, any place in the United States and the world. Unfortunately, the opposite is true when you get to the Black African community. They have the highest infant mortality rate, no matter whether it's in Brazil, Florida, New York, California. And I think what we're missing, what you're not talking about in any of this, is the genetic basis of what's going on here. Because just by looking at the data, and I have data that goes back to 1900, and it's basically the same every year. It's the same type of information. It's not really changing. There have been some changes which are due to vaccines becoming available to treat certain particular diseases. When we're talking about particularly Black African population, we might want to look into sickle cell anemia and sickle cell trait, which you didn't mention, because one of the reasons that CDC claims the infant mortality rate has taken a dip in the Black African community is because of the introduction of pneumonia vaccines. One of the major causes of infant mortality being pneumonia as a complication to sickle cell disease. And I think, these things have already been looked into, and you're going to be collecting data. That's an ongoing process that other people have done and have been doing. I'd like to see some more meat on a program. We, frankly, are a very small community. So if we did a study here, it's mathematically insignificant, statistically. We don't have the number for the base to do that. And we should understand that. If you really want to do a program on infant mortality and causes, you have to do it on a much larger basis, where you have hundreds of thousands of women involved. And, 1,000 live births is not going to really give you it may give you a picture of what's happening in this community, but it's not going to get into the genetics or the disease processes that are going on. And that's all I wanted to say.
Okay, so I can respond to that, and I believe Cecilia could respond to that as well. And I want to keep, stress that what we found in our previous look at this data was the prematurity and low birth weight as a primary cause of infant mortality in our county. I also do want to say that this process of a FEMR is welcomed across the state. What I had said in my earlier comments is that we wouldn't look at a one-year period because of the small number of deaths. We certainly understand that. That's why when the Department of Health undertook this study before for an analysis, we looked at 10 years of deaths, because then you're looking at trend data, and that's going to give you a more significant picture. That's why you can't look at this quarter by quarter. because that's not going to tell you anything, because we do have small numbers.
You have to normalize it.
Yes, and certainly, the other piece that I would encourage you to watch is from the series on natural causes and when the bow breaks. And they've done numerous studies that they've looked at when when parents come to this country, when African American parents come to this country, their outcomes in that first generation are better. But by the second generation, they are falling at the level for Black infants in this country. They are not maintaining what they were when they first came. So those results are worse. What the research is indicating now is looking at issues of toxic stress on infant mortality. I do know that that's something that the district, with all of your examination about social determinants of health, that is common to what you're already looking at for influences on health. As part of that FEMR, you are looking at all of the data, the medical history, you're looking at everything about that infant, everything about that mother, about that family. So any information on types of illness or disease would be captured, information on protective factors like breastfeeding, or factors that are not protective in terms of smoking. All of those things are captured and discussed in that analysis. It's quite a robust discussion, and it's not unlike what I already participate on for the other committee. So it's not, infant mortality is very complex. If we were able to get the quality of data from just well, it's not just, but an epidemiological analysis without the in-person expertise, we just do it on paper. But it's very important to be able to talk to those mothers, talk to those families, talk to the service providers, and find out those interventions, because otherwise we don't have a hope to improve what's going on in our county. I mean, do you have something to add, Cecilia?
Well, just in terms of social determinants of health, there's so much that happens with the families, and as you're talking about being able to interview the families, we wouldn't only learn about their medical history and the genetics that you're referring to, but we would also learn about their practices at home, what is going on, and how when we learn those things, then we can make an intervention based on what practices are going on in their homes. And toxic stress, it's just an issue that many women carry throughout their lives. And when you look at specifically the Black community, that is something that is not, they have been carrying it for years. So once the woman is pregnant, it doesn't end there when they have been dealing with toxic stress for most of their lives. So with this type of group, we would be able to look comprehensively at all of those factors, not only the genetics.
You're talking about this county, infant mortality. What do you have, 2 or 3? I mean, it's terrible. 1 is horrible. But you're not dealing with significant numbers here. If you're going to go over a 10-year period, how many patients are you actually going to be examining and case histories? And how is that going?
7 to 10 each year, that's about 100 kids.
How many are in?
About 100.
In this county?
Over a 10-year period.
Over a 10-year.
Over a 10-year period.
There are about 28 in a 3-year period.
How successful are you at getting the families to open up and give you the information that you're seeking in a study like this? Do they seem fairly open to it? Because you know, you're going into their home, you're interviewing them, they're very private people.
Some are and some aren't. I mean, you're requesting and you're explaining the purpose of the FEMR, but they have the right to refuse.
Yeah. I had a case in St. Lucie County where we had 2 deaths, and there were actually Latino moms, and they were about 2 weeks apart. Well, one of the moms kept asking us to come back in to the home, and so I was covering for a nurse, and when I went into her home, she would just sit and talk to me. And it was interesting that she wanted us to come back. I don't know that everyone is like that, but those particular moms, they wanted us to
That's,
come
you're
back.
talking from a Latino
Yes,
perspective,
yes,
whereas
but-
would you get the same reaction from an African-American family or a,
You know what?
and I'm just asking.
Sure. It depends.
Okay.
With Healthy Start, what I can tell you is that we are building relationships.
Yep.
And so regardless of whether it's a Latino mom or an African-American mom or white mom, we are building relationships, and we show them that we are coming back. We're not here just to get your information because we need something.
Gotcha.
We're coming back, and that's how you build relationships. So it's all about the training. I know that the Health Council of South Florida, they're very good with training. They're very good with coming into the homes, with doing interviews. This is what they do. So, yes, we're gonna have some folks that are not gonna want us to come in because it's gonna be hard on them.
Right.
It's reliving, all the trauma. But then, who knows? We have to try and figure
Right.
it out,
I think the partnership between the two organizations is important. I think you have to start somewhere. I think the fact that this is an awareness, and even though there aren't a lot of deaths in the community, there are more than we would like. And the fact that you must start a program like this speaks volumes to the rest of the country, and the rest of the counties, that we're doing it. And if we can address it and build that trust, I think it's worth it for future generations and for these people. If they come to this country and they're healthier in some way, and then that goes down, this kind of a study is valuable. And you can't put a price on it. It's very, very important, and it's important for community, the health of the community.
I totally agree on that point, as you know. I hate to put it this way, but the reality is we spend a fair amount of money, the taxpayers, the community spends a fair amount of money, about $1.5 plus or minus $1 million a year in the Partners Program, which principally provides prenatal care for anybody, whether you can afford to pay for it or not. And one thing about that program that I'm really proud of and really impressed with is that it's the same treatment for anybody, no matter what. And not every element of medicine can say that. But the second thing is that the infant mortality rate, neonatal mortality rate, and other metrics have remained stubbornly higher in our county than the Florida average. Now, they've been up and down because you talked about the volatility of these numbers because of low numbers, but the reality is they've remained slightly higher. Data suggests that they're getting exceptional clinical care through the Partners Program. And there are a lot of metrics on that, not the least of which is a nationally recognized index called the Kotelchuk Index that talks about the amount and the quality of prenatal visits. And our county, at least the Partners, the entire county, is considerably higher or better than the state average. And yet, despite that, you have this persistently higher rate. In our attempt to improve the health of the community, it's got to start with babies. Partners and our hospital represent the delivery of, the hospital delivers about 90% of the babies born of Indian County residents. About 10% go somewhere else. And then about 2/3 are through the Partners Program. So we're spending money to support that. I think it's money really well spent. However, we need to make a return on that investment, and we've got to have more impact on the infant mortality number. We need to be, with the quality of this program, we should be better. So clearly other elements are involved. We need to know and understand what it is. You've done a femur study in the past, but it's been quite a long time, as I understand it.
And it was multi-county, it was more informal than this, but it was the effort that we had. That's been probably about 10 years.
Well,
So you're asking for 65,000 now?
60.
60? Oh, we're getting a discount. Okay, the 5,000 was a mistake.
Abstractor was 25.
What's that?
The medical abstractor's position was 25 and not
5,000,
30, is
not
that
30.
correct?
Oh, okay, never mind, okay.
well,
So you're asking for 60.
Yes,
If we were to approve it, if we gave you 30 now and 30 in October, would that be sufficient for you to complete this study?
yes, because it's going to take some time for us to plan and even to start the process and get things implemented, so that would.
And when do you expect that we would see this report?
Well, we had estimated really a 6-month period, and then for preparation of the report, I mean, probably 8 months from the start, maybe less than that. We need to talk more specifically with the Health Council. The only other comment I'd like to make that I always make when you say about the quality of the Partners Program is that if the Partners Program was not there, then that would be a gap. But the fact that it is there, it is about 25% of the whole infant mortality piece. If it wasn't there, that would be a problem, but it is. And they do a good job. And we have adequate prenatal care. There's been tremendous effort to get women in earlier. I mean, all of those things are excellent, but there's still more to what goes on.
yes.
So I would like to move that we approve this expenditure.
And I second it.
Other discussion? Any other comments?
Well, I just-
Barbara, do you have anything? Hold on a second.
No, I've heard better what the trustees have said. It was a little difficult hearing everything Miranda said. So I don't have any questions at this point.
Michael, you have
Yes,
a comment?
I just want to address something that Alan was talking about. We talked about the care, the level of care, and thank God for our Partners Program, which has been a marvelous, marvelous program. But the CDC has studied the level of care, and they found out that it's irrelevant. They studied black African-American female physicians, and they have exactly the same infant mortality rate as the general black African-American population. And you would think there would be a change there. You're dealing with an upper echelon of society who's getting the best possible care. And that's why I think this problem is beyond our scope here. It's more into truly understanding the genetics of the situation, and we're not doing that. You're collecting some numbers, very small, and that's not going to get us much. I mean, these programs are being done in New York and Philadelphia and Chicago, dealing with tens of thousands of people, and they can't figure it out. I don't think where we're going to do it, dealing with 1 or 2 a year. I just don't think so. I think they could use the money better elsewhere, as my opinion.
So let's go around and vote to what the motion is. So Mrs. McChrystal.
I definitely think we need this program. I mean, we're not going to solve the problems of the world, but we certainly can help solve some of the problems of the death rate of infants here in this community and see what is causing it.
So that's a yes.
I'm a yes.
Thank you.
I'll be briefer, yes.
Okay, Tracy.
I'm never brief. Just ask them.
I think the information is important and it sounds very comprehensive, so I say yes.
Michael?
I think we're just collecting data that's already been collected, and I don't see, there is some probative value in it, but I don't see where it's going to help the community in the sense of providing a cure or better care for these people, for the infant, and lowering the infant mortality rate. I think the money could be used elsewhere better.
So that's a no.
No.
Okay, Barbara?
I'm going to vote yes on it. I did discuss with Anne Marie earlier today. along with what I've caught now. So I feel comfortable enough to say that I would be in favor of it.
Okay, and I am going to vote yes, although I do think it is outside the scope of our normal, what we are charged to do, doing a study, and it is very much related to population health, not necessarily services, but I will vote yes for it as well. So,
Well, we appreciate your confidence, and Dr. Weiss,
Yes.
we will make sure that you get the information and hopefully change your mind.
All right, because I've been doing this for a number of years now.
We have two.
prove him wrong. Prove him wrong, Miranda,
Okay.
okay?
All right,
Thank
go
you.
for it.
Thank you so much.
Keep us abreast of what you're doing.
Thank you.
Okay, don't go 6 months without something on it.
Okay, next we have the Visiting Nurses Association, Lundy Fields.
Good evening, wise and legendary
All
Madam
right,
Chairman,
Move along, Lundy.
and her
Whoops, they gotta pull up like-
esteemed
Yeah.
trustees and residents of Indian River County. So we are giving you a two-part presentation. One is just a quick review of FY18, since we were delayed or postponed from the December 17th meeting. And then just a quick update on the Vulnerable Village Initiative. So go to the first slide, or the second slide at this point. So the VNA received, go to the second slide quickly. The VNA received a budget of $369,000 for FY18, and our actual spending was $339,000. I don't know if you want to go into the details, but I thought I would just move right along from that. The majority of the hospice services, as you see, are in routine days, and so that is where the bulk of our services were rendered in the hospice services. When we look at our hospice quality scores are at or above Florida and national averages. So we have a number of amazing angels that float around this county that take care of people in amazing ways. We look at home health. The majority of our home health services, surprise, surprise, were in the RN skilled nursing area. And again, we look at our home health quality
There we go.
scores. And you can see that we are better than Florida national averages, where you want to be better and or higher, and we are lower where you want to be lower, which is in the rehospitalization rate. Believe me, the Cleveland Clinic's going to hear all about that as well. Looking at the mobile unit, you can see that our volumes picked up in the fourth quarter in terms of total patient volume. We started a little bit of additional marketing to make sure people knew where the mobile unit was, and we started moving it around a bit. And this slide, I'm really not going to go into any detail, but you can read that for yourselves. So if I move on to the Vulnerable Village Initiatives, are everybody okay with that? I figured it's so old, it's like, well, I don't even want to go over it. But anyway, okay. So just want to take a couple minutes on our Vulnerable Village Initiative. And we are really excited about the strong, collaborative healthcare network that we have created. And Anne-Marie Suriano was there today. Anne-Marie McChrystal was there today at our meeting. We have 21 people, or 21 organizations signed up for the healthcare collaborative. That has been very successful and well-attended meetings. We look at our volumes on the mobile unit. I didn't put in December, but it's at 160. But you can see that our volumes really started to take off in August when we really started to let people know that the mobile unit was back in business and available to them. And regarding the Vulnerable Village Initiative, we really have to thank our guiders in this process. We were only able to connect with the two vulnerable villages that we're focused on right now, Gifford and Wabasso, because of our healthcare champions. And so these four people have really helped us a lot to develop this program. And also, just in terms of awareness, we want to thank the Department of Health Julianne and Miranda, really for taking us out and making us aware, and I think some of you as well, aware of the health needs that we have in our county. So I want to thank them for that. Here's here's our current schedule of where we are. So we're out there 6 days a week. Half of those days are within Wabasso and Gifford, and then we also are capturing vulnerable areas in our county to the south of us and then to the west of us as well.
And where do you see the volumes?
Pat, do you want to? Oh, yeah. So Pat Nipper is here. She's our director of the program. And so where do you see the bulk of our volume these days?
The bulk of our volume is actually the combined Gifford sites and Oslo. That's where we're busy.
Right, yeah. Oslo, when we were initially looking at rescheduling the bus, we had Oslo on the table, but the volume and the commitment there from the residents was too high, so we had to keep Oslo in the mix, yeah. So just some pictures of when we're parked at the Gifford Youth Achievement Center, and then, as you probably well know, we're at Martin Luther King Park, which is right near the Gifford Health Center. That's been very popular, and our location at Allen Chapel off of State Route 510. Now, here's the return, and now we've talked about the increase in volumes that the ER is experiencing right now. Now, we're basically preventing between 2 and 4 people a day from going to the ER. So we're looking at about 26% of the people coming to the VNA's mobile unit that were headed to the hospital. And 23% we're going to wait for the VNA bus to be available, and I know a chunk of those probably would have went to the hospital as well, but they know the VNA mobile unit was available, so they wait around for that. Now, Pat has created a great tool to identify people so we can track the outcomes of this program. So we committed to you when we started this initiative that we would track 30 patients and that we would come back to you after we have them on board with us for a year to reveal the clinical and programmatic outcomes of these specific 30 patients. Now, to be able to get 30 people to agree to do and participate in a clinical study, we developed this health kit tool, and it's a very comprehensive tool that Pat Nipper and her team created. And once they have completed this tool, we suggest or recommend that they be a participant in this program. And so right now, we have 62 patients. 150 people have completed this, probably even more by now, but probably 160 something by now. Over 60 people have said they might be interested in this program, but by the end of January, we will have 30 people enrolled in this clinical study. We plan to come back to you in March with the first sort of early fruits of that study, because they'll have an initial assessment, an assessment after 30 days, an assessment after 180 days, and after 360. So in March, we'll be able to report to you on the initial assessment in the first 30 days. So we'll share that with you. So that is it. So
One of the things that we talked about was where these patients was finding them a permanent health home as well.
Correct.
Are you also, the expectation is that you're going to come back to us and say, they have it, here's where they're going and what they're doing.
Correct.
Are you following that in these patients? Is that?
Yes, that is the ultimate goal, is to connect them with the PCP.
Right.
So we would expect that the majority of them would either be at TCCH or at Whole Family or maybe a private practitioner in Indian River County. But the goal of this program is to get people connected with a long-term provider, not to continue to come back to the mobile unit. We're just there for primarily urgent care needs, although it's a good and bad thing. We have amazing nurse practitioners on this bus. And it's been out there for, 20-something years. And people have created relationships with some of these people. So, but we're doing the job. We're saying, no, you need to be connected with a PCP in the community, so we do guide people in the right direction there.
Okay.
Can I ask you a question about these numbers you have here?
Yes.
Total visits performed on the Healthcare on Wheels, 1524, indigent patients served, 114. I'm presuming, it's page 7 on the,
Yes, okay.
I'm presuming that when you say indigent patients, those are people you're able to get proper documentation from.
Oh, yeah, absolutely.
Is that right?
Yes.
So could you talk about the other 1,400 patients and what segment you think they represent, even though they didn't give you the proof that they were indigent?
Correct, yeah. So, so the other 1,400 patients are going to be sort of a combination of a lot of things, but the bulk of them are going to be children and children receiving sports or school physicals. There's a good chunk of those. Another chunk are people receiving employment physicals. And then you just have the underserved, the ALICE population that we've talked about, who have the income, but not enough. They're strapped and they come to the mobile unit. I was there one day with a mother with her child, was a 3-year-old daughter. So as soon as she came on the unit, I got off and left. But I circled back later and found out that the daughter had strep throat. The mother had no means to pay for that particular visit that day, but is employed. So they don't really meet the financial the financial guidelines of the district number, but they're there on the mobile unit. So some of those people in the early days we saw for free because we figured we were there, and at that point in time we were paying for the most of the cost of the mobile unit.
Lundy, it's going to be important for you to keep those numbers exactly, because the district is talking about moving or considering the poverty level, perhaps advancing it to 200 or so we're not there yet, and it'll be a while, but you have to keep those numbers. So we know how many people are out there in that population. And that's going to be important to where we go, I think, as trustees, with deciding where we're going to go, if we're going to elevate the level from 150 up to 200 or 250. So your information, Health Department, all the organizations, that information is going to be vital to our decision-making, I think.
Correct, yeah. When we are capturing reams of data on the mobile unit, so we will be able to provide to you a lot of detail on exactly who's coming to the mobile unit, what payer source they have, a lot of information that Pat and her team are collecting right now.
And there's a lot to not just, their work, what kind of employment, and do they have health insurance within the employment or not? Yes, I know Pat Nipper, you're gathering all that information. It's going to be vital to our decision-making.
So I wanted to address that. Over the last several months, we have been collecting information through our health screening tool, asking people, do they work outside the home? If they do, what do they do? Right. We're finding out through those questions whether or not they work, what they do, what their occupation is. Are they unemployed? Are they part-time workers? We're finding out that kind of information. We're also asking them if they have insurance. Now, we don't have the capacity to verify whether or not they have insurance, so we actually do take them at their word because we just don't have the capacity. And we've said that at previous discussions and previous meetings. Mm-hmm. But we do track if they come to us, for example, if they are part of the ALICE population, let's say, for example, the working poor, and they tell us, yes, I have Aetna, or I have Medicaid, or I have some other insurance. Typically what they're conveying to us is that their copays and their deductibles are so exorbitant that they just can't afford to pay those fees. We are tracking the reason why they came to us if they have insurance. So It could be anything from, I have insurance, but I can't pay the deductibles and the copay. I don't have a primary care physician. I couldn't get into a doctor's office for several weeks. You know, it was a weekend, the doctor's office was closed, so, you know, it was here or the emergency room. So we are tracking that data, and I think we'll have a wealth of information.
Going to be important,
to share
very
with you.
critical.
That's great.
Yeah, we have over 850 now. Surveys that we have done for patient satisfaction, which has a lot of that information relative to whether or not the patient has insurance, and if we refer them out to somewhere else, we actually are tracking that. Of course, the collaborative has decided they want that to be patient choice, so we're in the process of doing BAA agreements with some of the clinical providers so that we can share that information and find that out. And then through the health screening tool, we have, in just 6 weeks, we collected over 150 health screening tools that are giving us that deeper level of data on patients that have even expressed to us, you know, when I look at it on paper, I knew I came in here and I needed to lose a few pounds, and maybe I knew I came in here and I don't sleep through the night, but when they start answering all of those questions and looking at their full health picture, they really are starting to think about, through those conversations with the nurse practitioners, the status of their health and the changes they need to make. And that's what we're hoping to achieve through that. So we'll have a lot of data, and along the way, we can share that with you, and anything that you want to add, we can certainly add questions to either of those, either the survey or the tool. We can certainly add any other questions for information that you might want to know at this point.
I want to point out one thing for you that you had mentioned briefly. Doing the employment physicals, the pre-employment physicals, is a tremendously important thing that you're doing. Because I've been there with the people coming in and they want a pre-employment physical. And they went to a doctor, oh, come back in 2 weeks or a week and a half, 3 weeks. And they need that piece of paper that afternoon, that day. And of course, a lot of them can't pay for it. And what you're doing, that service is critical to helping these people survive.
Mm-hmm. Yeah, just one of the gentlemen that Pat told me about that is probably going to be in this study was someone that is that profile of a person that the Cleveland Clinic profile down at Weston when I went down to that program. And this is like a late 20s, early 30-year-old male who isn't super active. They like video games. They do a lot of gaming, and they have hypertension. Mm-hmm. And these kids have high blood pressure. And Pat was talking about this gentleman, after he filled out that health screening tool and saw his health situation, decided that, oh, I think I need to be in this study. And it's very interesting, because we think about a whole different kind of population. And I was really surprised when the Cleveland Clinic brought that to our attention as health leaders when we went down to this program, that was one of the things that they're focused on, and that type of profile there are a lot of those people out there like that. So I think this will help us with that as well as we move forward.
Well, hypertension leads to a whole lot of other issues in that too,
yeah.
and it's the number one. I mean, if you can fix the hypertension issue, which should be able to be managed, okay, if you catch it, then you can fix a lot of other issues, so.
Correct, yeah.
Yeah.
Diet and exercise, I guess.
Was that my son? No, I'm kidding.
No.
Not mine.
Could have been. Just saying.
Okay, any more questions?
Thank you, Lundy.
All right, thank you very much.
Appreciate it. Any unfinished business from the? Okay, new business. We have Phil Mattson here. Welcome, Phil.
Hi, good evening. Phil Mattson, I'm with the Indian River County MPO, and that's.
Oops.
He's a county guy. He was in here before you.
I've been in this room.
Oh, you had to put
Thanks.
your name in, too.
Oh, my gosh.
I not only do my homework, I listen. Dr. Hugh McChrystal, Drive Extension, and we want to make sure that the acknowledgement and recognition remains in this proposal. So let's move ahead here. And what do I hit to advance, right? Perfect. So why I'm here, the county owns 37th Street. Currently, it's a 3-lane roadway, and it's beginning to exceed capacity. We actually rate roadways on a letter grade scale from A to F, just like a report card. That's based on what the vehicle to capacity ratio is. Like anything, it could be over capacity, it could be overstuffed, then nobody gets anywhere. And we're coming very, very close to exceeding the capacity on 37th Street right now. When you add invested trips, which are trips that we know are coming from approved development, we're just about there. And if we don't do anything about it, we're going to greatly exceed capacity. And all these programs, as wonderful as they are, and as much as I've benefited from the medical center as anyone, unless you can get there, you're really not gonna be able to carry out your mission to the community. So we want to make sure everybody can get complete mobility and take advantage of the programs. So all medical trips are funneled through 37th Street, as you guys know, and that's pretty much the fundamental problem. There's a lack of parallel roadways in the area. Everybody is coming up Indian River Boulevard in US 1, down Indian River Boulevard US 1, goes over to 37th Street. Even if you come in on 36th Street, if you're headed southbound on US 1, you have to exit on 37th to avail yourself of a traffic signal. So that's the problem in a nutshell. When you take a look at the aerial photograph and you look at these statistics, there are 150 of 410 acres vacant south of 37th Street, 160 of 260 acres vacant north of 37th. So this is all in play. This is all can be developed mostly for medical related purposes in the future. So what can we do about it? If we were to extend this 3-lane roadway into a 5-lane roadway, currently you have to run the gamut to get out of treatment now, especially if you're making a left turn. It's only going to get worse if this were an extended roadway. And because there's 27 driveways in a 1-mile stretch, which is way too many, it's really not very good access management or consolidation of driveways. That same movement's going to get harder and harder in an expanded roadway. And we can't signalize every entrance. You know, there's spacing limitations between signals that create a lot of rear end problems and stacking. So 5-laning, it's going to be a challenge, cost, disruption-wise. Obviously, there's going to be a substantial disruption during construction were we to do that. But even after, I mean, we are going to have an expanded roadway that's going to carry still virtually all the hospital-related traffic and be much closer to the building footprints. We do a computerized travel demand forecasting model in conjunction with DOT, and these are extremely sophisticated. And we put in here, you can see the diagonal line here. It's a virtual markup of our roadway network. We put in all the productions and attractions, as we call them, all the sources of traffic, and automate it and take a look and get a good forecast of how many cars will be siphoned off by other roadways or by widening existing roadways. So we ran a base case analysis, 2040, future population and demand with no roads. We ran one with a southern extension of Aviation Boulevard to Dr. Hugh McChrystal Drive, and then one that goes all the way up to 41st Street. And what we found out is we could build this new roadway, the Aviation Boulevard extension, and relieve 37th Street, really forestall it at least through 2040, having to do anything to it. We'll get a good amount of traffic on the new road to the south, 9,000 trips, a much smaller amount of traffic to the north, maybe half that or less. That would be an equivalent amount of traffic to, say, 26th Street out by St. John of the Cross at 74th Avenue, just a kind of slightly above a neighborhood level traffic flow. So the south piece will get substantial traffic, the north piece will get a much less amount. We'll also in the process be helping out some adjacent roadways, US 1, for what that's worth, and it might be worth a few green stamps from DOT. My kids don't know what green stamps are. Nobody's kids. Nobody's grandkids know what they are. But anyway, moving ahead, could eliminate the need to widen 37th, less disruptive, benefits the adjacent property owners as well, so we've gotten consent from them for that purpose. County would obviously construct, own, and maintain the new facility. But think about a few additional advantages. If we had something with Aviation Boulevard that crossed US 1 instead of just dead-ended on US 1, we could probably make the case for DOT when they reconstruct aviation in US 1 to put an overpass in. And that's a critical component here, right? You'll be able, with the FEC traffic that we're seeing, there's inevitably going to be problems with the FEC Railroad with stacking of trains. We see a lot more train traffic in the picture, double trafficking. When there's an incident, the trains are often stopped and block our crossings. You know, and an overpass for emergency-related traffic for everyone really would be a beautiful thing. But you can't really do that. You can't have an overpass that goes over a major arterial roadway, then dead ends and makes an abrupt left turn. You really have to continue it somewhere. And then emergency access as well. And by that, I'll give you a little illustration. So I like things that move, you know. So here we have two arrows that represent the traffic that leaves the medical center on a daily basis. And I sort of made their width commensurate with about the volumes of traffic that we see. It's about an equal spread. When you have a blockage, all the traffic has to go the other way. You really only got one way in, one way out in this case. And creates quite a backlog. And last January, there was a bicyclist hit on Indian River Boulevard, created a 5-hour delay on the boulevard and in this area. So by having alternatives, no matter where you have your blockage, you've got at least 3 other ways you can go. Were it here, which is a critical spot, and which could happen, because this is US 1 at 37th, you'd have at least 3 bypasses around it. Whether you're going north, south, or east, you know, you'd be able to not be affected by this. So those are extra benefits to keep in mind. Our Public Works Department drew up 3 very good schematics here, good alternatives of which way this road can go. Now's the time to do it. It's through mostly empty property. This is probably the best project I've seen, or at least one of them since I've been here. You know, it's our chance to kind of control the future and the destiny of this area. And it's vacant property. It's going to get a driveway one way or the other. There's going to be access. But we could have a driveway that doesn't connect to anything and terminates, or we can have, you know, a roadway that serves the traffic and serves area traffic as well to the medical center. So those are the 3 alternatives. In terms of the piece right at 37th Street, our Public Works Department drew this up. This is keeping the alignment as far away as possible from the rehab center at the northeast corner of 37th and Dr. Hugh McChrystal Drive. Let's see, so this would be a little bit of a realignment from where the existing roadway intersects, a little bit to the east, which is a good thing. These are the 3 alignments, you know, head to head. This 3rd alignment probably leaves very little to develop in the extreme lower right-hand corner here in the southeast corner, but that might be good for drainage, you know, for the entire alignment, and leaves more developable property in the northwest side. And this is probably another good project, a very good illustration of something that we did here at the MPO that there were a few skeptics about it on this one, little pushback we got, but almost invisibly, we've really done a lot of good for the flow of traffic here. And this is Royal Palm Point, Royal Palm Boulevard in 2001. And you can see the traffic welling up here, heading southbound on Indian River Boulevard, backed up all the way to the Barber Bridge. It used to back up to it and frankly over it. I mean, some cars couldn't make the left turn coming over in 2001. And the reason in a nutshell was it was a 5-point intersection. And a lot of us have lived in towns that had 5-point intersections. They become huge choke points. And there's one in Fort Lauderdale, Wilton Manors, Stewart at Confusion Corner. And we were able to remediate it. I mean, we basically came up with a way of removing one of these points, and this is how it looks now. And it's a much more symmetrical geometric design. We're able to get traffic going simultaneously in multiple directions. According to the Kimley Horn study, which is an engineering firm, it probably saves 20 seconds every time you approach this intersection. So you multiply that by everybody who's ever been through it since 2017. We've taken an entire signal phase out. And this is comparable. This is something that we can do. The time to strike on it is now. Who knows, if on the 5 points we had more development on it, we might not have been able to pull it off. And what we're asking for today, a very specific ask. We'd like the hospital district to consider the roadway segments and authorize your staff to work with county staff to prepare a draft agreement for right-of-way. So be happy to answer any other questions. Stan Bowling's here, Community Development Director, and yes, sir.
In all your planning, you're talking about going out to 2040. Have you considered the change in the automobile by 2040? You may not be having drivers driving the automobiles.
To my wife's consternation, every night. I really do stay up thinking about it because this is my business and this is what I do. The Secretary of Transportation came to our last MPO meeting and he said, We know this is coming. There'll be an inevitability to automation. We call it autonomous and connecting vehicles. And if you want to really impress your friends at a cocktail party, you say, well, the future of transportation is ACES. It's an acronym. It stands for Autonomous, Connected, Electric, and Shared. So that's the combination of all those technologies, shared being Uber and Lyft and all that. We all know it's coming. Very few of us know what the implications of this are. Some people think that auto ownership, individual auto ownership, will go the way of the past. You know, the railroad barons used to have their own railroad car in the Clint Eastwood movies and stuff, and you know, everyone uses shared, it's taking a train, a shared public ride now. So it's possible there could be autonomous fleets of drone vehicles that show up when you call them. When you go to some cities now, you know, Uber's there, almost no wait whatsoever. They're in the lobby waiting for you. So we don't know what the implications are. Will that really reduce traffic? Will the laneage be taken up by more and more Uber cars? That's what's happening so far in Miami. So we're still planning for some conventional roadway construction and roadway widening. I don't think it's an imprudent thing to do at this point, but lacking a crystal ball into the future, you know, you could always convert these things into something else if you needed to.
Because this deals with the right-of-way that's right up against the hospital, do we have to contact Cleveland Clinic and go through that process as well?
Well, one of the things, and I talked to Jennifer a little bit earlier, knowing this was coming in, but that if we are okay with it and want to continue the work, then I would ask Jennifer, because we do have a new easement agreement with Cleveland Clinic and with, and actually with the VNA as well is involved in that. So I would ask Jennifer to make sure that this is consistent with that as well. I know you have talked to the hospital already.
Oh, yeah.
Yeah.
Yeah, it's, you know, our alignment follows pretty consistently straight and hugs the extreme eastern portion of that property. So, well, we do have that right-of-way agreement with the hospital. And
What kind of timing do you see on, assuming that we go along with it, everybody goes along with it, when are you going to be able to do this?
I'm guessing it would be 2 to 4 years. Roadways never go quickly. We'd have to budget for it at the county level. We already have some funding that we're thinking on spending on other roadways. We'd want to do it quickly, though, because once too much development comes in, the right-of-way and the alignment, you know, it could frustrate our attempts. I don't know, I'd say about 2 years. 2 to 3.
This is 2 lanes?
Yes, 2 lanes.
That come across.
But 2 lanes, according to our model, will be plenty to be able to handle, you know, you got your choice, pick your poison, 5 lanes on 37th or a 2-lane alternative roadway.
And I
We
like
could-
the idea of the overpass. What kind of odds do you put on that?
Pretty strong. There's a pretty strong consensus concern about railroad traffic and railroad safety. Even some of the jurisdictions that embrace the new rail proposals are getting pushback because of some of the fatalities that are occurring. And they're looking to put overpasses in down there, so.
Good.
I'd say pretty strong. It's a new DOT priority.
Okay.
So can we take do we need a motion on this?
Yeah, motion to approve
Okay,
the recommendation.
which is to move forward to working with them, having Anne-Marie and the staff work with them to put that on the condition that Jennifer goes through the easement agreement that we have and that it's consistent with the easement agreement. So,
Yeah, I would so move.
a second?
Second.
Okay, all in favor?
Aye.
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 Ms. McChrystal?
Well, I still have some questions, but I'll say aye because we're going to be looking more into it. I still don't quite understand. And you did mention St. John of the Cross. You know where that is?
Yeah, 74th Avenue and 26th Street.
Right, okay, just wanted to make
That's
sure.
about the volume we'd get on the north piece. On the southern piece, we'd get a little more than that.
Exactly.
What I try to think of a road that would have a frame of reference of the sorts
Yeah.
of volumes, because, you know, anytime we build a road, we get half the people saying, nobody's gonna use that, and the other half say, that's a superhighway. You know, so traffic's kind of a tricky thing, so I try to put these in the context of similar traffic to what the model's predicting to give you a little background. So it won't be too bad to the north. To the south, you'll see some use.
Yeah, they never wanted to build Indian River Boulevard north either years ago, but they did, and it was a blessing to
Thank God.
have it. But, and I'm still confused as to, not widening 37th, you know, and then taking just a two-lane road there, because right now, when you're going up 37th and you want to turn left to go to perhaps the B&A or the emergency room or something like that, the traffic can be really backed up. Now, that's going to be still a two-lane road, so coming this way, and so, I don't know, but we'll have to look at it very closely, I think.
All right, so we did approve moving forward with it, and Jennifer will look at the agreement that we've got and make sure that we're in line with that.
Thank you, and we'll be in touch with staff.
Yep.
Appreciate it.
Thank you, Phil. Appreciate it. Any other business from anybody? Any public comment? There isn't hardly anybody left. You want to make a comment? Now I'm looking at you, you, Michelle. Okay, all right. Then we are adjourned for the night. Thank you.